I'm Dr. Craig Escude, the host of IDD Health Matters, a podcast where we talk about health, wellness, and health equity for people with intellectual and developmental disabilities. Hope you enjoy it. Welcome to this episode of IDD Health Matters. I'm here with my friend, colleague, mentor, David Ervin. Welcome, David.
Thank you. It's good to be here.
Great. So I want you to start off by just talking about how you got into the field of supports and services for people with intellectual and developmental disabilities.
It's a story of pragmatics, frankly. I graduated college with a degree in psychology and had made a decision, a fateful one as it turns out, not to go right into graduate school. And so I had a degree. I didn't have any real life experience, and I needed a job to pay for car insurance. And so I went to work for a community provider of supports to folks with autism. And I was a DSP. I was making $4.25 an hour, just enough to pay for my car insurance. But I fell, as it turns out, irrevocably in love with the idea of coming alongside another human being and being a part of their journey to a quality of life that they defined. And it was love at first sight, and I've been there ever since.
That's a story that we hear so often. People either fall into it, which is kind of what you did, it's kind of what I did, just fell into this field, right. Or they have a connection with a family member and want to do something in the field to improve the supports and services.
It seems to be the case.
And when we fall into it, what I found is you either know really quickly that this is something for you or it's not for you. And for both of us, it ended up being the thing for us.
Indeed.
Yeah,
indeed.
Absolutely.
Yeah.
So tell me about the organization you're currently with and what you do there.
Yeah, happy to. So I'm the Chief Executive Officer for a community-based organization based in Rockville, Maryland, just outside of Washington, D.C. We are called Mome, and we support about 230 folks.
What does Mome mean?
Mome is a Hebrew word. Our roots, our founding was in the Jewish community in the Washington, D.C. metro area. And so in a nod to those roots and that history, our organization's name is a Hebrew word, and it means place. It means many things in Hebrew, but it means place. Not place like a physical structure, but place. And for us, this becomes manifest in this notion of self-determined supports where people get to choose their place, the place they take in community, in society, in the gestalt of humanity.
I like that.
And on the back end of that, there's a fundamental notion that if people with intellectual and developmental disabilities aren't in their rightful place, my community is lesser than. As a result. And so this is enormously compelling for us. We support about 230 mostly adults with IDD in and around the Washington, D.C. metro area.
So, David, I know you've done a lot of work in this area related to health equity, improving supports and services in the health-related supports and services. Mm-hmm. We'll come back to Mome in a minute. Mm-hmm. Go back to or tell us about some of the other things that you did.
So we stumbled on this, I think, another cosmic accident. The year was 1997-ish, and the organization for which I was working at the time was supporting a woman well into her 50s who had fairly significant and complex health support needs. And we were in Chicago, or the suburbs of Chicago, and it took us forever to find a primary care doc who was willing and able and comfortable in delivering primary care to her, not touching specialty care. And the trick of it was that to access that health care with that particular PCP, we had to drive an hour outside of Chicago. And we decided that wasn't okay. And we spent a fair bit of time sort of fetching and moaning about the problem. And then something just snapped. And in 98, we decided that rather than just complaining about it, that we should do something. And And so we did, and it wasn't terribly sophisticated at the time. We created what was then and remains called today the multidisciplinary clinic that was sort of anchored in a community provider. We brought a teaching hospital to the project. We brought a psychiatrist, a neurologist. We created, without again much sophistication, a multidisciplinary approach. And it felt right, it sounded right, and we started collecting data. And from about 1998 until about 2004, we had collected enough data that suggested we were really onto something. I then moved on to an opportunity in Colorado, and I worked in Colorado for 14 years and had an absolute blast. There, rather than admiring the problem and doing more complaining about it, we sort of recognized early that there was a real lack of resources for thousands and thousands of folks with IDD. And so we ultimately developed a healthcare collaborative project called that ended up in a clinic called the Developmental Disability Health Center. We did that with the local federally qualified health center. And the last time I knew much detail about it, it was health home to about 1,000 adults with IDD. And again, the data just continue to tell a compelling story. It turns out, I know this is not rocket science, and yet it turns out that the data show that when you deliver culturally accessible, competent, and culturally relevant healthcare to people with IDD, good things happen.
Quality of life might improve.
Health-related quality of life. We're watching
Necessary pain and suffering.
Exactly. Well, and it's health outcomes, right? So, and you know this. We tracked longitudinally the easy stuff, health markers. So, obesity and morbid obesity are outrageously high among folks with IDD. So we monitored obesity rates and through BMI and waist circumference. We monitored hyperlipidemia. We monitored hypertension. All of these conditions, which medicine knows what to do with, when you deliver competent healthcare, our data show that rather than just continuing to be elevated, we can actually bend health outcomes. And inevitably, that helps us bend the cost curve. And the real kicker is folks with intellectual and developmental disabilities are telling us, we're not sort of projecting this on them. They're telling us they feel better about their health, they feel better about their life. So it's a quality of life issue. This is, again, a no-brainer. And I know you know this, but sadly, even in 2023, there are so few of these projects, and there's no real community of practice that has developed among those projects they're in the country and they're doing good work, but it's still much work to do.
Friends for Life Residential Care, specializing in support for individuals with developmental disabilities, offers services like adult day support and home health care. Emphasizing empowerment and quality of life, we live by the motto, "My ability is stronger than my disability." We are currently hiring, welcoming those passionate about making a difference. Learn more and explore career opportunities at friendsforliferc.com.
So before I really got to know you, I ended up visiting that clinic because I was looking for examples of what other people were doing. Plus, I was taking a trip to Colorado.
Yeah.
And I'm like, we're going to make a side trip and go visit the clinic. And I spent several hours there, and I was very impressed by there was an interdisciplinary approach.
Absolutely.
Which is needed. I've mentioned this before about the importance of an integrated approach to healthcare for everyone, because so many things are connected. Our minds are definitely connected and influence our bodies, and vice.
Turns out,
imagine that.
Yeah, right.
There is actually a connection. But that's a very important part of a clinic, I think, or an approach to providing healthcare to everyone, including people with intellectual and developmental disabilities. And that was a really nice thing that I saw there, and that you developed. So you are in the DC area now, and you're working on another initiative in that area related to health equity and availability of health care for people with intellectual and developmental disabilities.
We are. So I was at Mome for, I sort of tell the story for dramatic effect for 5 minutes. And my phone rang, and I'm thinking, here I am in the nation's capital. I've moved back to the place where my career started, ironically enough, and I'm in the nation's capital, and it's rich with resources. So I didn't come back with an eye to developing another healthcare delivery system for folks with IDD. And 5 minutes-ish after I got there, my phone rang. And it turned out it was a mom who had just sort of found me accidentally through some publications that I've done in this space. And for 45 minutes, she fought back tears and talked about how challenging it has been for her with I believe her son with autism is in his mid to late 20s, and how hard it has been for her to find in the nation's capital primary care, specialty care, resources that are designed for folks with autism and other intellectual and developmental disabilities in health promotion and wellness. And I didn't need another invitation. So we have recently hosted a health equity summit where we brought a good number of the nation's content experts to the table. We locked ourselves in a hotel room and said we're not allowed to come out until we've designed a conceptualization of a healthcare delivery system.
You did feed us some great food.
Yes, well, and we had some good laughs, didn't we?
That we did.
So it was so compelling and such an inspirational couple of days. We've now developed and finalized a manuscript, a proceedings manuscript that will, in essence, lay out the blueprint for how we're approaching this work. And our goal, our objective, is to stand something up here in the next 24 months. So we've put ourselves on an aggressive agenda. Here's the really good news. While the DC metro area, as it turned out, didn't have and doesn't have meaningful healthcare options for folks with IDD. Everyone we have spoken with, from medical schools to dental schools to hospital systems to governments at the county, state, and federal level, everyone with whom we have spoken has literally said, where do we sign up? And so that experience is different to what we faced now 12 years ago when trying to stand up the Colorado project.
You know, that speaks to an observation that I've noted too over the years and the years that I've been in this field. There is more momentum. It is small, but there's a little more momentum. There's a little bit more of an understanding and a recognition that this is something that the healthcare system in general does need to address.
Yeah.
Would you agree with that?
Totally.
In the past few years?
Yeah, no, totally. I think that's right. And I have to say, it is really down to the sort of fierce advocacy of people with IDD, their families for sure. But I think there's a growing number of health professionals. There is a growing number of academic institutions across the country and a growing number of community providers who have finally and fully not only understood the challenge, but have come to a place where we just can't admire the problem any longer. We have to be done talking about this, and we have to instead pivot ourselves to developing solutions, to evaluating those solutions for efficacy and impact. I think developing a community of practice is absolutely essential. There are really good projects in the country. There's a humongous one in New York City. There's another in Westchester, New York. There's a project in Culver City, California. There's the project in Colorado, and there are others. And for reasons that mystify me, those projects and the principals who are working in those projects are not connected in any meaningful way. So I think one of the things that we need to think about, in addition to developing more healthcare delivery systems around the needs with and for folks with IDD, is how do we then cobble ourselves together so that I can learn from your work and you can learn from my work, and we both can contribute to the scientific literature so that we can learn from one another in a far more coordinated way than not. Because I end up bumping into, I'm sure you have the same experience, Craig, we end up bumping into really, really impressive sorts of approaches to this work. And we scratch our heads and we say, now where have you been? Well, we're all here, but how we connect ourselves to one another so that we learn from one another and then can take projects to scale, then we can stop talking about the need for specialty clinics and specialty approaches, and it just becomes a part of our healthcare delivery system writ large.
So specialty clinics, specialty approaches, is that widely accepted as the best option?
That's a trapdoor question.
I'll help you with that. The answer is no. There are people that think that having to go to a specialty clinic is not integrated, and I don't fully disagree with that.
Yeah.
However, if I have a cardiac issue, I will go to a specialist. If I have a gastrointestinal issue, I will go to a specialist.
Yep.
Sometimes I might have to travel further to be able to do that. I think there is enough uniqueness to this field that we should have availability of specialty clinicians. I also think that anyone should be able to present themselves to any practice of any type.
That's right.
And receive a basic level of competent health care.
Yeah.
And that's, I think, both of those options, it's not a this or that.
It's an and also.
It's an and. Yes.
Yeah, I agree. I had the great privilege of leading grand rounds at Wake Forest Medical School just about a month ago. And I gave a lecture on developmental medicine, which is sort of the growing but still infinitesimally small specialty or subspecialty for folks with IDD. And I left that experience feeling really positive about the future, and sort of here's why. So you make the point that there is an ideological debate between creating specialty clinics for folks with IDD. And for some folks who look at and consider that, it's segregated medicine, right? I totally get it. I also have made the very argument that you just made so beautifully to justify, to explain at least, or to engage in a dialogue around the need for specialty clinics, right? But here's where ideology and pragmatics inevitably collide. I think that every physician in the United States, I won't go global, but every physician in the United States ought to get a minimum amount of training in medical school. And I think that residency should cover developmental medicine. And I think that post-residency fellowships should at least be available to any physician, family doc, internal medicine doc, or any of the specialties, to learn about this part of our community. That does not exist. The University of Colorado School of Medicine only very recently, and kudos to them, huge credit to them, actually added hours on disability content and IDD particularly into the medical school curriculum.
That's great to hear.
Well, and you know how unbelievably rare this is.
And challenging, and I get it. There's a lot to learn and only so much time.
Exactly right.
This is valuable and important.
Absolutely. And so, fast forward to Wake Forest, and they don't have any disability content in their curriculum, and they, just like you said, sort of are wrestling with an absolutely jam-packed curriculum. Where do we find the space becomes a real question. So if that's true, and if because of that reality, we're not in fact depositing health professionals into their practices with a base knowledge and a sense of confidence and competence, then we struggle. So the project that we are hoping to stand up in the Washington, D.C. area is not only contemplated as a healthcare delivery system, it is also contemplated, frankly, and we are aspiring to greatness. We want this to be a world-class training center as well, so that docs who graduate out of medical school with or without content in their curriculum on developmental medicine have a place to go in the nation's capital where they can develop their skills. I'm sure you did not graduate from medical school with any content on developmental medicine.
Absolutely none.
You had to develop it over time, which makes you now one of the world's experts in this space. Well,
that's very kind.
If that's true, and I think it is, then experientially, we have to create opportunities for practicing health professionals to learn their craft. And so I can't make the nearly 200 medical schools in the United States immediately adopt curricular content on IDD, but we sure can create training opportunities and a place to get them for folks who are interested in learning.
Well, David, I know what you've done before in other places that you've been, and I have no doubt that you will achieve this and you will accomplish it. And I can't wait to see it and be a part of it. So there's a little thing that I like to do at the end of a talk here, and I call it 3 and 3. So in about 3 minutes, could you tell the listeners or talk about 3 things that you think would have the most impact, especially if there are things that our listeners could be a part of or be involved with that can have the most impact to improving health, wellness, supports, services, the lives of people with intellectual and developmental disabilities?
Yeah, it's a great question. I can't do anything in 3 minutes. So I think for folks listening who are part of my community, the provider community, there are easy opportunities to create partnerships with health-related institutions in the communities in which they're doing their work. And what I mean by that is we, for example, have entered into a partnership with Georgetown University School of Medicine. Their community health division is led by an extraordinary physician called Dr. Kim Bullock. And she has created in the community health division opportunities for community-based learning. And it was easy enough for us to reach out, and persistence matters, as you might imagine.
It does.
To reach out and to create a partnership so that we are part of now a community of providers where these health professional students can come into community for community-based learning opportunities to learn more about people with IDD. For us, for example, that is a drive right at the heart of social determinants of health, which is such an essential framework for us to think about creating solutions. So that's one. 2 is engage people with IDD directly. Don't just bring them to the table, but remember the role that they play in not just where and how they get healthcare, but where and how they want to receive their health care. What are the health outcomes that are important to them? We've got a massive un- and underemployment rate among folks with IDD, and there's a whole raft of reasons for that. But one of them surely has to be the health status of people with IDD is so disproportionately poorer when compared to people without IDD. And it turns out to hold a job, to build a career, you need to be healthy enough to lean into that career. We know people have skills. We know people have talent. They ought to be able to enjoy a health status that is at least reasonably commensurate with their peers without IDD.
Could not agree more with that. Could not agree more. And, and I'm cutting you off and I'll give you your extra minute.
Yeah.
but we talk about, there's a concern sometimes when people talk about health care and medical care for people with intellectual and developmental disabilities, that we're talking about the medical model where we're trying to fix the disability, but that's not it at all. it's really the opposite of that when we're trying to improve access to capable and competent healthcare. That's evolving society to meet the needs of everyone in society. So I just wanted to kind of, for everyone out there to really recognize that this is not the medical model way of thinking. It's improving society. It's looking at the social determinants of health, which make a big impact on our health overall.
Absolutely. Right. Absolutely. Yeah. Disease is not disability. Disability is not disease. So cast off that old medical model nonsense. And then thirdly, I think folks, and it takes a village. It really does. We spend a fair bit of time talking about public policy. As a doc, that Medicaid rates of reimbursement are terrible. The old fee-for-service system just does not work for folks with IDD. Well, amongst community providers, we interact and interface with the Medicaid system all the time. It happens to be through the Medicaid waivers. We are not that far away from the traditional fee-for-service models. What's emerging in too few states for my liking, but what is emerging, and everybody can pay attention to this stuff and get involved at a policy level, are Medicaid Managed Care models. Medicaid Managed Care relies on two things that I think are game changers for us. One is it's a capitation system, right? So imagine a world in which your health care, let alone your long-term services and supports, are no longer on a fee-for-service platform. That is a game changer. The other piece, the second of the two, and there's lots to this, but the second, I think, seminal piece to the Medicaid Managed Care system is care management. So in my world, we're very used to service coordination, case management. We call it 1,000 things. One of the things that you touched on early in our chat today is the need for all of us, sort of an interprofessional collaborative model. 100% correct. I take it one step further to bring systems of care together. So we have to integrate systems of care so that the long-term services and support system and the healthcare system, and then the third one that I refer to as the social and developmental support system. This is family and the personal trainer at the club and your friends and people who are in your world. If we are not all rowing in the same direction, inevitably we will not be able to achieve the sorts of outcomes that folks with IDD deserve and want. So care management, you plunk care management down in the middle of those three systems of care. That brings everybody along. Our DSPs are now talking with our docs instead of being talked to by the docs. We are a part now of the health team because, as you said to start us, it's a perfect way to end. We are indivisible. Our brain health, our psychological health, our emotional health, and our physical health are all inexorably linked. We can't parse you. And so all of the systems of care that touch folks with IDD have to be brought into the equation. And I think Medicaid Managed Care has the real potential, and no more carve-outs, just an editorial sidebar, has the real potential to change the reality for folks with IDD in many fundamental ways.
The last point I want to make about that or related to that is we're talking, you mentioned acute medical care services and long-term services and supports. And sometimes we don't always make the connection that if we're not doing a good job on the acute care side, we will probably require more long-term services and supports as well. So, keeping people healthy will also impact positively, I think, the cost of long-term
absolutely
supports as well.
Absolutely.
Yeah.
Absolutely. And, it's quadruple bottom line. So it's better care that delivers better outcomes at a lower cost and a happier, more satisfied, more fulfilled, more actualized patient person. So, that's the way to go. That's the way to go for sure.
David, you have opened our minds, as you always do. Every time I talk with you, I think about more things, I learn more things. And again, you really are a mentor in a lot of ways. I love your enthusiasm, your drive, your initiative, and I know you will accomplish the things that you set your mind to, and that's really exciting. And I can't wait to hear updates on where we go.
Definitely.
Where you go with this.
Definitely.
On another time.
Yeah.
Thank you so much for being part of this
Thank you.
today,
Yeah.
for joining me, and keep doing what you do.
Amen.
Thank you for doing it.
Yep. Thanks, Craig.